Hi, everyone. Let's go ahead and get started. My name is Isha Kumar, and I am a fourth-year doctoral student at Rosalind Franklin University, and I'm also one of the health psychology interns at the Jesse Brown VA. On behalf of Northwestern University's Feinberg School of Medicine and the Jesse Brown VA Medical Center in Chicago, I'd like to welcome you all to today's Health Psychology Seminar. Our seminar will continue to be held virtually through WebEx until December 2nd. For those of you joining us live today, if you could please type your name into the chat box and where you're joining us from, your program name and location. That way we can get a sense of who is joining us. And you can also use the chat box to type in any questions you have during the talk, and then I will relay them to Dr. Conviser at the end of her presentation. So before we get started, if everyone could please take a second to make sure that your microphone is muted, that would be great. I'm honored to introduce Dr. Jenny Conviser, Assistant Professor in the Department of Psychiatry and Behavioral Neurosciences at the Feinberg School of Medicine at Northwestern University here in Chicago. She is also the founder and CEO of Ascend Consultation in Healthcare. Additionally, she directs Sports Psychology Services at DePaul University. In the past, Dr. Conviser has presented in this seminar series on sports psychology. However, today we are very lucky to have her presenting on the business of health psychology. Please welcome Dr. Conviser.
Thank you so much for that lovely introduction. I really appreciate it, and all the technical assistance that you all have been offering today. I feel much more expert with Zoom than WebEx, so thank you so much. I want to thank Dr. Sarah Cantonese as well, Jason Washburn, and of course Dr. Muscat for the opportunity to be here today. I haven't had a chance or an invitation to talk about health psychology for a while, and I think this is a really cool time to chat about it. So thank you, and thank you for sending in your questions. I've included them today and want to make sure that I really speak to the issues that are of interest for you all. Welcome all questions at any time. I need to, this is just to get you in the right mood, you all, to listen and kind of connect with the topic. So we all know what health psychology is, but I thought I would just remind us all what we're talking about or thinking about. And you know that it has to do with the interface of health and illness and wellness and emotions and behavior. And it targets the intersection of these factors. If I actually went and looked up the APA, or American Psychological Association, definition of health psychology, and do you know that they say it's the intersection of health and behavior, but they leave out the emotion word? I just put that in because I thought it was relevant and it might be helpful for this discussion. So health psychology can target any number of entities. Y'all can think about 50 more than what I have here, but just off the top of my head, I'm thinking, man, health psychologists work in programs in schools, universities, government agencies, corporations, all of this. Primary care, public, private, government, religious, teams, families, individuals. So as working in health psychology, you can work with an individual or a larger entity or anything in between. There are a variety of different modes of working, or different roles as a health psychologist. And it's actually one of the things I love about this particular field is that there is so much variety, and it is pretty easy to shift from one role to another. But health psychologists do jump into the consultation, prevention, education mode. Sometimes it's teaching, sometimes it's informing. We often do lots of kinds of intervention, evaluation, tracking, research, and sometimes analysis. Sometimes we're called in just to help other professionals think about what they're working on and to weigh in with our opinion about how all this fits together. So in terms of responsibilities, again, health psychology can go a lot of different directions. We can work on risk reduction, or we can work on health optimization, or anything in between. These are just some of the pieces or some of the arenas that we can find ourselves in terms of health psychology. Reducing health disparity, huge in the news right now. Tracking lifestyle change, all kinds of tracking possibilities in the world right now. And if we're doing interventions or we're trying to understand what's working or what's not working in the world, someone needs to look at that information and track it and understand what the trends are, will inform more practice. Health psychologists do lots in terms of prevention, health promotion, facilitating recovery, either from illness, injury, or other. Oftentimes we're part of a group where we can design programs or healthcare systems and think critically and creatively about, again, how the different pieces of these entities all work together for the benefit of the client or the patient. So any of these possibilities here. One of the ways that health psychologists are commonly recruited or invited into a space is for healthcare compliance issues, whether we're asking a professional to help us with patients or clients who they want to improve their compliance with recommended medical regimens. It might be as simple as, hey, we want this individual to be able to come back to the office periodically. We want someone to be compliant in terms of dental checkups or mammograms. And it may seem simple, but the reality is that medical compliance rates are not ideal. Medication compliance rates are far from ideal. Dietary compliance, don't get me started. Exercise compliance, improving, but really only 20 to 30% of the population currently exercises as much or as frequently as is recommended by the American College of Sports Medicine. Sobriety, that is a wonderful, wonderful field, and to be able to work in addictions and help folks adhere to their plans for sobriety, very rewarding, and there's a huge place for health psychologists to weigh in and be part of that world. Harm risk reduction and smoking cessation. We know that folks try to stop smoking 11 times. What are we missing? What do we need to do better? What can we do better? Health psychology can weigh in on all of these things. The literature shows that medication compliance for illnesses or healthcare conditions like blood pressure is about 60%. So if a doc writes you a prescription for your blood pressure or your cholesterol and sends you home, the compliance will be about 60 to 70% at best. If a physician prescribes an antibiotic for your child's ear infection, and they say, take this antibiotic for 10 days, after 5 or 6 days, when the kid's sleeping better and in a better mood and his ear's not hurting anymore, the parent kind of, oh yeah, I'm supposed to finish this antibiotic. That was what was recommended. But there's kind of a relaxation of vigilance, perhaps, a lot of things going on. And it kind of stops there for the most part, 70%. Compliance rates to give your child antibiotics according to physician recommendations is at best 70%. Dietary compliance is a really tough one. It's really hard to eat. No one eats perfectly, and if there are specific medical conditions or health-related conditions that require extra vigilance in terms of dietary regimens, it's really challenging for folks to do that. And this is one of the areas that I do research in and work in, is the whole arena of dietary compliance, whether that is for special health-related conditions, weight-related conditions, disordered eating or eating disorders. And the reason that I do a lot of that, y'all, is because when I first jumped into Northwestern, I came from the University of Chicago. I was there doing work in behavioral medicine. It was great. We did rotations through all the different departments. And then I had the opportunity to come up to Feinberg. And the reason that I started working with weight and eating-related conditions at that point was because nobody else really wanted to do it. And I was like, oh, I'll do it. That's kind of interesting. And I wanted a job at the time. So very pragmatic. I was like, well, I'll give it a try. So that's how I got started with this. I'll give you a little bit more background later, but it was a very pragmatic moment. It was about work and paying the bills. In terms of exercise compliance, again, only a small percentage of the population exercises according to what the recommended world standards are. In terms of sport compliance, does everybody do exactly what coach wants you to do all the time? Do you do your ideal rehab after you have a sports-related injury? No, no, and no. And does everybody go home with their recommendations from their physical therapist for their rehab of their knee injury and make sure they do their stretching and their icing? Absolutely not. The compliance rates there are about 50%. And again, sobriety and smoking are common. These are common areas where health psychologists are asked to weigh in. So what about health psychology and COVID-19? Any space or room for health psychology in this arena? Politics aside, not talking politics, but there is a pandemic, there is a virus, and what can health psychology do to contribute to this arena? And have any of you heard much on the news or newspapers, online, in printed literature about what health psychology is saying about the current virus? I haven't heard very much. I'd be interested to hear if you have, because I think there's a bigger place for health psychology in this arena specifically, as well as many others. I think there's a bigger place for health psychologists in many, many spaces right now. So as I thought about health psychology and opportunities in terms of the current virus and pandemic, I'm thinking education. Health psychologists understand what a contagion is. They understand statistics. They understand things like what's the positive sensitivity rate? What are the testing rates? What are the percentages? How to read that graph that they show. Easy for all of you. You've had the training, you've had the experience, you have the knowledge, but not always so easy for whoever's watching the news. So I think there are huge opportunities for education. Simple things like what's a pandemic? How is that different from an epidemic, et cetera, et cetera? Should I be afraid? Should I not be afraid? Should I worry, not be worried? These are emotional components of managing and coping right now that I think are really important to address and could be very helpful. How do I understand risk or not? And what's the best or appropriate mental set right now? What should I be afraid? Will that make me safer or not, et cetera? Good questions. What about compliance rates in terms of things like wearing a mask or hand washing, social distancing, shelter and quarantines? Health psychologists are supposed to be the best at this. They're supposed to be the ones who know the most about these situations. And I feel like what I'm hearing in the news is there's certainly a lot of political discussion about these issues, and there are some medical discussions in terms of explanation of what's recommended. But there is always a gap between what's recommended and what is being described and what's actually happening in terms of behavior. And that's where you all can jump in and make the world a better place. Just jump right in and find out what that gap is about and help us get creative and smart and wise about helping to solve those problems and getting it better. No perfect out there, but better. I think health psychologists also do an amazing job with thinking about coping. Right now, because of the virus situation, the financial complications are bigger than ever. Different for different people in different situations, but everybody has some financial worries. The social isolation is a challenge. People do better when they're with people. Where's the health psychologist on the news talking about how to help yourself navigate social isolation and why it's really hard? It's not because you're weak or bad or not a human being. It's because social isolation is usually really hard for people, and whatever was going on before is now going on worse. So now it's going on in spades. So I think health psychologists can jump into that discussion and have ideas and remedies and structure that would help with that. Health psychologists also are helpful in terms of dealing with grief and loss and the uncertainty of this time, the uncertainty of the world at many times, and in terms of making recommendations about structure or time management or coping skills health psychologists are great at this because they understand the interface between behavior, health, conditions, and emotions or mental conditions. So this seems really strange to be talking about myself. Usually I'm talking about the research, so forgive me, but I'll jump in because that's what your questions were about. So, all right, I will give it a go. Take a deep breath. But so how did I get into all this? My undergrad grew up in Minnesota, land of hockey and skating and all of that, long winters, big family, lots of sports because there wasn't else a lot to do. Grew up in a small town, cornfields and hockey, that was it. So education, my undergrad was in education. I was a D1 gymnast in college, so I had that experience of what's it like to deal with coaches and training and aggressive training, high-level competition, with travel, with study. I, at one point, became a gymnastics judge, so I knew about the sport from the perspective of officiating. My undergrad was education because I had no clue what I was going to do with my future. And I wasn't so worried about it either. There's a huge worry right now. Everybody wants to know before they know. If I have another athlete who's 13 years old and says, I don't know what college I want to go to or what I want to be after college, I'm like, wait a minute, you're getting ahead of yourself a little bit. What are you doing on Monday? So, but at the time, I was working on undergrad in education, doing a lot of gymnastics, traveling, competing. My master's degree was in exercise physiology because when I graduated from my bachelor's, I was like, what do I want to do? And what I discovered was that I knew I could coach gymnastics or train gymnasts. And so I found a college that would give me an opportunity to study exercise physiology because it was sort of interesting. And I knew I could get it paid for if I taught or helped to coach the team. So I became an assistant gymnastics coach for a couple of years and did a master's in exercise physiology. And then I got a job coaching at the University of Wisconsin-Madison. And that was where Bill Morgan, who is one of the premier all-time great world famous health psychologists, sports psychologists, at Madison, and studied with him and did 130 hours of a PhD in sports psychology while I was a head gymnastics coach there. And then I said, this won't give me a clinical degree because it's a research program. So came to Chicago, got a PsyD, loved it. I did a whole year of testing, so much theory. I thought it was a great counterbalance to my other education. The CEDS is a certification in eating disorder treatment, and the extra S is about I am eligible and certified to be a supervisor of people learning how to treat eating disorders. And the CMPC, which is, most people don't know what it is called Certified Mental Performance Coaching, which is a certification that you get. You take a lot of tests, you have to meet a lot of criteria, and basically it means you're certified to be able to sit with someone and think about performance, whether that's mental performance, whether that's corporate performance, artistic, musical, sport performance, that you have some specific training and have accomplished something in that arena. So those are all those letters. What are my responsibilities in terms of health psychology? They evolve over time, and that's one thing I love about doing this is I can do a lot of different things and I can change it up. So anything from teaching and supervision, staff training to case consultation. I love it when people call and go, hey, I have this client, what do I do? Or what are your ideas about what we can do next? I really enjoy research, don't always have a lot of time for it, but I love research and writing and love collaborating with folks at Northwestern or other entities as well on that. I had a chance to do a couple of really cool projects with Jason Washburn. He is such a brilliant mind, love him. And I also serve on a couple of editorial boards for a couple of sports psychology journals, and I founded and oversee the James Drennan Memorial Lecture at Feinberg, which is dedicated to prevention awareness of eating disorder matters, and we host a lecture yearly in Feinberg dedicated to that cause, which is really cool. I really enjoyed that, and that lecture, that funded lecture, was actually funded by a grateful client, a grateful patient. Very appreciative of that. And when I'm not working, I'm walking the dogs or groceries or meal prep, that kind of stuff, or go for a run or play some tennis or something. My clientele have a variety of ages. I love working with kids and parents all the way through seniors. And sometimes I do get a little bit more intrigued with something that is complex, or when there's co-occurring or more than one thing going on. That's kind of fun. I work with athletes. You all know that at this point. Performers, coaches. I don't know why, but I kind of get those calls. So I'm happy to work with whoever calls or pops in the door. It's absolutely fine. I really love the variety. And again, I started my professional career in clinical psychology doing eating disorders because that's where the work was. At that time, there were a lot of psychiatrists that were really way into working with schizophrenia, and that was fine. It didn't bother me. I was fine to jump in this other arena and have been there ever since. And I think it's been a really challenging but interesting way to use my health psychology head. So my approach generally as a clinician is pretty eclectic. I'll draw from any theoretical model and use whatever works. My mode of operation is I use the tool that gets the most progress in the least amount of time with the least disruption to the client or the world, and run with it. I use a strength-based model, so it's not about the client being, I don't really deal with people in terms of their pathology. It's a strength-based, which means I'm trying to help them develop or cultivate the strengths that help them achieve the goals that they want to achieve, help them get what they want out of their world. That's my focus, and I'll do whatever it takes to help them get there. One of the things that I think is that I would say characterizes my approach is that when someone comes in and works with me, I believe in their ability to make progress. I believe in their ability to make the changes that they want to make. It is not that I am thinking about a new theoretical piece, or I'm not just thinking that maybe they can get better. I believe it. You know, when Martin Luther King said, "I have a dream," they all went to watch the speech. He didn't say, "Oh, I have a thought. Anybody want to hear my thoughts?" No. People come in and they see me, or they see our team, or they meet with us because they know we believe that they are capable of getting better and getting more of what they want in their world, and we don't stop. I don't believe in working with someone if you don't have confidence that you can make improvement. And if we get into that place, we work very hard to find other services or other treatment entities that can augment our work, or where we can transfer someone. I don't believe in giving up on anybody ever. So we really are strength-based, we're positive, avoid shame and blame, and we try to build resilience and build capabilities based on individual strength. We don't try to excise the bad. We're not trying to eliminate the pathology. If there is pathology, we can work around it or past it. Let's build on the capabilities or the talents that person does have that can facilitate progress toward their goal. Okay, so some of my challenges, there's been a lot of challenges along the way, of course. There is no progress without challenge or setbacks or upsets along the way. Not a big deal, because I'm not surprised by them. They happen. They happen for everybody all the time. So I think some of the bigger challenges have been dispelling myths about mental illness. And one of the biggest myths, of course, in my arena is that people can't get better. They can't stop drinking, or they can't recover from their eating disorder. And I spend a lot of time and energy speaking with families or other medical care professionals and help them understand that yes, they can. Yes, they can get better, and yes, they can improve. And yes, people do recover from eating disorders. I encourage, a lot of time I spend encouraging clients to be less critical and more patient with themselves. In the current culture, there is this common belief, the zeitgeist is that, well, if I'm really hard on myself, then I'll make a lot of progress. If I push myself extra hard, I will be extra successful, and it just doesn't work that way. So we spend a lot of time encouraging people to be a little more kind to themselves. Of course, you got to work hard sometimes, but a little more patient with the process and helping them learn what works, what helps them be successful in what they do. I spend quite a bit of time helping families or medical care providers outside of the therapy world learn about how therapy works and taking some of the mystery out of it. And that's something I think that characterizes my work is there's nothing that they can't ask and there's nothing I won't share. I don't really have any fascinating secrets in my life that I would need to hide because there's not much going on. But I really like to take the mystery out of psychotherapy and out of behavioral complication and keep it simple and help them learn about themselves and about how behavior works and emotional growth works. And that's both enjoyable, but it has its challenges as well. A lot of challenge also comes in the world of weight-related matters and eating disorders. We have, of course, there's great press in our world to look a particular way, thanks to social media and a few other things. And lots of pressure in the sporting world, the performing world, the musical arts world to look a particular way and the belief that that will get you the success that you aspire to. And we all know that that is a sort of slippery slope because too much attention in weight-related matters means greater frustration, maybe more escalating weight-related worries and greater problems, not fewer. So it's a tricky area, but one that I really like. I like the challenge. So that's kind of in a nutshell, or maybe more than a nutshell, kind of what I've been doing or where I came from. I was at Northwestern for 11 years. So before I jumped into more of a private practice, but continued to maintain my assistant professorship at Northwestern and do the work that it takes to sustain that relationship. Still love it, still enjoy it. I like research. The pockets of research that I've been doing, you might be familiar with already, but I did some research with Sheehan Fisher and Dr. McCauley from the Children's Hospital at Northwestern on looking at the increased risk of eating disorders in when children have childhood illnesses with a dietary component. I mean, at some point a few years ago, I looked at Sheehan Fisher and I said, I think everybody's getting an eating disorder, even if we talk about diabetes or talk about cystic fibrosis. And we went and looked at the literature, and Dr. Fisher helped me pour through, literally thousands of pieces of literature. And yes, if you have any additional focus as a child for any particular necessary reason, you have an increased risk of eating disorders later in life and everything that goes along with it in terms of changes in mood and anxiety. The other pocket of interest that I've had, and these are all health psychology relevant, are dental health issues. Folks with eating disorders often have some serious dental health complications, but they can't talk to their dentist about it. So I actually did some studies to look at how little communication, and it was something like 85% or more of folks that go to the dentist can't talk to the dentist about their eating disorder, even if it damages their mouth and teeth, because they just don't have that relationship or that confidence that it'll be okay, or they don't want the dentist to reprimand them or lecture them. So guess what? They don't go to the dentist, and then that creates greater complication down the road. The other piece I did was I looked at post-purging oral care. We did a research project to look at folks that have bulimia. This is an online survey to see what do you do after you engage in some self-induced vomiting, which is, of course, an eating disorder, compensatory behavior, and what do you do in terms of your mouth care. And the American Dental Association advises that you don't brush because of the acids that coat the inside of the mouth and your teeth. And if you brush and use dental or toothpaste, which has abrasives, and the brushes of the toothbrush have abrasive, that you're actually doing more damage to the teeth. So the recommendation is to wait several hours, use a mouthwash or drink water, rinse your mouth out with water or mouthwash, but not to brush. And most people in the United States did not at that time know that. It's getting better. So that's a nice example of health psychology where you're looking at behavior, looking at illness, you're looking at emotions, you're looking at what can we do to make something better. And someone doesn't have to be in therapy for 20 years to learn how that something helps. And we're not saying, oh, it's okay to throw up, but we're saying there's something you could do right away to help take care of yourself and protect yourself from additional problems. The other pocket of research that has been kind of fun has been something called osteogenic loading. And this, again, came out of just experience and pragmatics and passion for my people that I get to work with. I learn so much from them. And our eating disorder folks taught me that they all have very poor bone mineral density because of chronic malnutrition and low body weight. So there were support groups we ran where I would have 5, 6, 7, 10 adolescents in a support group, and half of them were on walkers because they had stress fractures for the year, not like 6 weeks, but like 6 months, and it was really hard for them to recover from it. So what I did was started to look at the literature and say, what do you do for low bone density if you're a teenager, which is very dangerous because most of your bone is laid down in the teen and early 20s, up to like 22, I believe, for women. And the medications that are beneficial for people to take are contraindicated if you're pregnant or to be pregnant or on a longer term in more than a year or two, and have a lot of side effects like nauseousness and bone aches, and it's not good, and cancer risk. So I went to pour through the literature to find out if anything else could be done, and I found out that NASA space in Texas and in Florida were using osteogenic loading, which is a particular kind of exercise for the astronauts, because even when they train in a weightless environment, they lose bone mass very quickly. Or if they are in space, they lose bone mass very quickly. And so what they were doing was using this particular treatment called osteogenic loading to help to remedy the bone loss or compensate for the bone loss so that they wouldn't have osteoporosis at a very, very, very young age. And it's not real, there isn't a lot of confidence in the world about how it's working, but we're finding some amazing success. And then I called Catherine Ackerman at Harvard and said, what are you all doing? She's in the women's health department, and said, what do you think about osteogenic loading? And she said, well, I can see it for astronauts, but she said, I don't think we should use it because people with low body weight have very low, are fragile. Their bones are really fragile, and they might get injuries. And osteogenic loading is an exercise where you lift a lot of weight. You lift 1 or 2 reps, but it's very, very high weight because it puts the load on the bone that prompts the bone to reform the bone mass. Just like if you were doing weightlifting for muscles, you overload the muscle tissue, it causes the muscle tissue to kind of wake up or sometimes fragment. And it's the repair of that muscle that causes the muscle to prompt to reform itself and get stronger. Very similarly with bone, you're pushing it to work hard, and that prompts the reformation. And she thought it would be too dangerous. So the first study we did was we went to the makers of osteogenic loading equipment and said, could we look at your data? So we looked at 22,000 users from 11 countries and divided them by body weight, because when you sit on this equipment, it measures your weight and it's all electronically recorded information. And we found that, yes, indeed, the people that were very, very low body weight had no injury, no pain, no complication, and were doing this effectively for many, many years. So it's things like that that we learn from our folks. They teach us what they need, and then we can jump on board and learn more about what might be helpful for them. But the first thing we try to avoid is to say no. We try to say, let's look into it. And I think that's been really helpful. More recently, we've been working with, boxer community and martial arts community around the making weight practices. And you all know that many martial artists, many sports have a weight class where jockeys weigh in before they ride and weightlifters weigh in before they lift, and boxers or martial artists weigh in. And if they don't weigh in within a small range, they can't compete. If they can't compete, they can't make money, and that might mean the money to pay for their family to have food. So we're looking at how to help this population be more safe, and We're working with the WBA to try to learn more about how to help actually develop policies and prevention programming that will make the weight-in safer. And part of that is wider, keeping more stable weight over the years so they don't have to lose so much so quickly. These are just couple of examples I'm sharing for you here on the screen. Boxer Mr. Sousa was 26 years old, and died at a young age. Dennis Munson died when he was trying to cut weight. David Alexander Acevedo from Nicaragua was 23 years old, died trying to lose 10 pounds in 2 days. Martial arts fighter Jessica, included her specifically because it's not just about a guy thing. This is a woman. This is a everything in between thing too. All kinds of different folks from different countries are trying to cut weight, and she died at age 18 trying to make weight for a competition in Thailand. And recently we've had 3 or 4 just in the last year teens, one from La Crosse, Wisconsin, who was trying to sweat to lose weight. We've had very, very young folks from across the country died with this practice, and so we're actively working with some of these sport entities to try to see if we can remedy this. I mean, forever into the future, our athletes and performers are trying to do everything they can to have the winning edge. It's just if it goes too far or too much or too long, it's become so dangerous, and no one should lose their life over this. So why do health psychologists have a role in this world right now other than COVID? Well, to work with athletes like the boxers that I'm so privileged to work with. They're an amazing, warm-hearted, wonderful group of people. And we also have rates of mental illness or emotional disorders in this country that are really problematic. If you glance at this graph, I mean, no one pops out of the womb with depression, right? So at a very young age, the depression or anxiety, behavior disorder problems are lower. But look what happens over time, over the course of their childhood into their teenhood. The rates just escalate. It's more common for children to have some anxiety or depression or behavior problems now than not. That's really concerning, and that's why sadly to say, there are more opportunities for us to jump in and be helpful and work with families and communities and schools in a variety of ways. Of additional concern, demanding more from health psychology are rates of suicide. And if you look at this graph in front of you or this table in front of you, it shows data from the early 2000s, 2001 to 2017. Over a 16-year period, y'all, suicide rates increased by 31%. 31%. That is a lot. There's no way to think about that except that's extraordinarily sad. We need more from psychology. We need more from health psychologists to understand what's going on here. What is this about? And in the news at night, do you hear about suicide rates on the news? Not so much, but you do hear about, unfortunately and sadly, and I say this with respect, how many folks were injured by guns, right? What was the homicide rate? Suicide here, second leading cause of death in ages 10 to 34. And then the fourth leading cause of death through middle years and into senior years. And how this compares with homicide rate, there are more suicides, substantially more than homicide. I'm not saying either one is good. It's horrible. It's horrible. But we need to know more than just the data. We need to understand what's happening here. And we know it's not one factor. We know it's not just about poverty. We know it's not just about poor access to care. We know it's not just about disparity in terms of treatment, attention, resources, et cetera. We know it's a mix of a lot of things. And a health psychology mind is well positioned to be able to think about all the components of this particular problem and to do so effectively and responsibly. So I'm so glad you guys are interested in this topic. We need you. We need you really fast. So another reason why we need health psychology and to think thoroughly about the health state of our children and our families is because of the data on this screen that you're seeing, which is Common reasons for kids to be stressed. Look at the reported and observed. Kids have said, most of them, 78% of the kids are saying that they have observed kids being teased or bullied for their weight, for their sexual orientation. 80% for their race and ethnicity. Half people have observed this. Gosh, when I went to school as a little kid, the biggest deal of the day was like, you know, what you're going to trade for lunch with somebody. You're going to trade your sandwich for their cookies or something. That was it. For physical disability, we're seeing people harassed and bullied and teased because physical disabilities, their income, academic ability, religion, etc. It is not a safe environment. And then we have kids come home and go, oh, you're supposed to be happy. You're supposed to be joyful. You're supposed to be enthusiastic. Or why don't you work harder? There is an unhealthy state, and health psychologists are well positioned to help us think critically about how to make some improvements. Esra, can you help with this particular video? This is about Mary Kane. I don't know if you all know her story. She's a Nike runner, the fastest runner in the world at the time she was competing with Nike, and she tells just a couple of minutes about her story. And if you could just, it's like 2 or 3 minutes at the most, if you could stop it when she just says, and then she went home.
Yep, I will share my screen.
I hope it's of interest to you all.
The world's most famous physicist, and he told me I was a talent. During my freshman year in college, I moved out to train with him and his team full-time at Nike World Headquarters. It was a team of the fastest athletes in the world, and it was a dream come true. I joined Nike because I wanted to be the best female athlete ever. Instead, I was emotionally and physically abused by a system designed by Alberto and endorsed by Nike. This is what happened to me. When I first arrived, an all-male Nike staff became convinced that in order for me to get better, I had to become thinner and thinner and thinner. This Nike team was the top-running program in the country. Yet we had no certified sports psychologist. There was no certified nutritionist. It was really just a bunch of people who were Alberto's friends. So when I went to anybody for help, they would always just tell me the same thing. And that was to listen to Alberto. Alberto was constantly trying to get me to lose weight. He created an arbitrary number of 114 pounds, and he would usually weigh me in front of my teammates and publicly shame me if I wasn't hitting weight. He wanted to give me birth control pills and diuretics to lose weight, the latter of which isn't allowed in track and field. I ran terrible during this time, but reached a point where I was on the starting line and I lost the race before I started, because in my head, all I was thinking of was not the time I was trying to hit, but the number on the scale I saw earlier that day. It would be naive to not acknowledge the fact that weight is important in sports. Like boxers need to maintain a certain weight, or, everybody always ends up citing the math about how the thinner you are, the faster you're going to run because you have to carry less weight. But here's a biology lesson I learned the hard way. When young women are forced to push themselves beyond what they're capable at their given age, they're at risk for developing REDS. Suddenly, you realize you've lost your period for a couple months, and then a couple months becomes a couple of years. And in my case, it was a total of 3. And if you're not getting your period, you're not going to be able to have the necessary levels of estrogen to maintain strong bone health. And in my case, I broke 5 different bones. The New York Times Magazine published a story about how Alberto was training me and nurturing my talent. We weren't doing any of that. I felt so tired, I felt so alone, and I felt so trapped. And I started to have suicidal thoughts. I started to cut myself. Some people saw me cutting myself, and nobody really did anything or said anything. So in 2015, I ran this race, and I didn't run super well. And afterwards, there was a thunderstorm going on. Half the track was under 110. Alberto yelled at me in front of everybody else at the meet. And he told me that I clearly gained 5 pounds before the race. It was also that night that I told Alberto and our sports psych that I was cutting myself, and they pretty much told me they just wanted to go to bed. And I think for me, that was my taking that head where I was like, this is sick. I think even for my parents in certain ways, once I finally vocalized to them, I mean, they were horrified. They bought me the first plane ride home. And they were like, get on that flight, get the hell out of there. I wasn't even trying to make the Olympics anymore. I was just trying to survive. So I made the painful choice, and
All right. Thank you. I'm going to jump back to the slides. Can you hear me okay? Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. So at that point, she went home, and not all sport arenas are like that. Not all sport experiences are that extreme. But some sports, some music, some artistic, some corporate, there are unsafe environments everywhere. And we need to keep in mind that there is a point of diminishing returns and for all things, including what one does to one's body. You can train, you can work hard, you can push, but there is a cost, and sometimes that cost is too much. And health psychologists can help people kind of realize and be better informed about decision-making and when to push hard and when not to push hard. It's vital, and to help folks think more about short-term and long-term factors in their health. Eating disorders come with a lot of cost, emotional, mental, physical, fatigue, medical complications, lots, and with high risk of premature death. So many folks believe that mental illness or that problematic behavior is maladaptive or wrong. And what we encourage our staff and what I encourage myself to do is, before I think of something as just wrong or bad, cutting bad, suicidal urges is bad, to understand the problematic behavior and to try to work to understand its adaptive function. This will help you know how to help the individual identify problems or underlying origins of the difficulties and how to help them make the next steps. We stay very far away from declaring that someone that is resistant is being bad or wrong. We understand the resistance because there's purpose in it, there's meaning in it, and we aren't going to change it or break through it until we understand what its purpose is and find other more adaptive and healthy ways of addressing those needs and that purpose.
Dr. Conviser,
yes.
Sorry to interrupt. I don't know sharing your screen.
Oh, you can't see the screen? Okay, let me look here for 1 second. Now, can you see it?
Yes.
Okay. Okay, can you see it now?
Yes.
Okay, great, thank you. So understand the reasons for the resistance and don't just declare it's wrong or bad. We have to understand what it is and then help the individual make their way to something that is safer and more adaptive. But we don't blame someone or shame them for their reluctance to change. Change is really tough. So here are some of your questions you posed, which I loved your questions. Top things that have made you a success. Well, I kind of see myself as evolving and not yet quite there, but I think eclectic training was really helpful for me. I think it helps, especially in health psychology, to have a little bit of a science background or an education background that's informed what I do. My experience working with amazing staff, amazing professionals at Northwestern for 11 years was fundamental and foundational for me, and I'll always really appreciate that. When I decided to go to private practice was after 11 years Northwestern. At that point, there were some fiscal decisions, financial decisions that they were making, and they needed to dial down some of the eating disorder treatment, and we needed to take our client population and create that treatment for them outside of Northwestern, just because the fiscal decisions they were making didn't leave space for that kind of care at that time. So it was very pragmatic. It was just, I've got these 40 people on my client list. I have to go make a place for them because the climate was changing at Northwestern, which it was changing for all hospitals at that time. So very pragmatic. Mistakes that I made when I jumped into private practice, I really was made. It's always good to donate. It's always good to be generous with your time, but I gave away a lot of treatment, and I think I would be more self-protective if I had to do it again. What are the pros and cons of insurance? You have access to a larger client population, and they have some benefit of their benefit support, their fiscal support, but it is costly and a little bit time-consuming for those billing services. How long does it take to ramp up in terms of income? It's hard for me to predict. When I started private practice, I went in with very low expectations and just said, let's take this a day at a time and see how it goes. And I always recommend a plan B. Wendy Belarby, who's a psychologist for the Chicago Bulls, is a huge advocate. When all the team comes in day one of the new season, she sits down with them and says, when are you going to plan for your life after basketball? And she says it starts today. The first day of their professional basketball career, she says, go for it, plan your next step. So I always was dipping into private practice or health psychology or the business, but I was always kind of thinking, well, if it doesn't work, what am I going to do next? But it's gone fine so far. Someone asked about LLC. It means limited liability corporation. There are many different kinds of corporations. You can Google them. It's really easy. There's an SC and a CC, and each different kind of corporate structure has benefits and protective factors. And an LLC, limited liability, means they can't come after your personal property if you get sued badly for something. And there's a few tax benefits, but each different kind of corporate structure has different benefits that may suit your interests and your needs. What's necessary to start a practice? Very little, especially with Zoom, like, hey guys, go for it. And you just have to be careful you get the HIPAA version of Zoom, and be careful about, privacy matters, of course. I'm saying if you, enjoy your work and enjoy collaboration, and I don't think it takes much more than that, really. I think if you all, because of where you are in your life, you're getting good training. I think that's fundamental. How much does it take to do the billing per week? For about every 10 patients, we probably spend for you as a therapist might spend up to an hour, but it doesn't have to even be that much. It depends on the kind of billing structure that you're signing on for. It can really vary, but you can make it more simple and more user-friendly depending. What are the successful strategies for attracting clients? Just be good at what you do, know your clients, stay within your scope of practice, and just enjoy your colleagues. If they know what you do and how you do it, they'll share clients with you and refer to you, and that's the word of mouth is huge. No one gets their therapist from like the sign on the corner by the bus stop. You just don't see, an advertisement in the magazine for a clinician, go, oh, well, that's a nice picture. Oh, look, she has credentials or he has credentials. You hear how someone is doing and what kind of work they do, and that's why they sign on, because they believe you have what might benefit them. Is there a sequence of events that should happen before opening a practice? Not necessarily. I feel like some of the questions, this is very overanalyzing, but I feel like some of the questions you asked were kind of the what's right, oriented to what's the correct way to take the next steps. Use your gut sense, use your intuition, follow your own path. It doesn't need to look like anybody else's. It can be yours. There's not a right or wrong way to do this as long as you're ethical and work with integrity and keep your folks safe. Get good training, but stay in touch with your emotional world because that weighs in a lot in terms of navigating your next decisions. The pros and cons of working with colleagues, just surround yourself with people that you enjoy, that you respect, they respect you, and it's really nice not to be isolated in a practice. It's nice to be able to bounce ideas off each other and to support each other. That's a lovely part of the work. And I enjoyed that part at Northwestern full-time as well. I mean, I still am in touch and do work with many, many folks at Northwestern, and that always makes it enjoyable and really intellectually stimulating as well. Is there a book or website? Not really. I built my own website. I still kind of dabble or help build it. We use a template. We use like Squarespace or something, and for $20, you don't have to hire a fancy marketing team to jump into that. Okay, I know the time has gone really fast, and you can usually feel free to share these slides. I have some recommendations here at the end about how to move forward in a world that's less biased and more thoughtful about self-care and more considerate and equitable about resources for all people, regardless of what they look like, with an emphasis on transformational relationships, not transactional. Transactional is when you tell people what to do and how to do it. Transformational is when you connect with each other, connect with your client, and make a we. We are all going down this yellow brick road together. We're going to see what we can discover. Let's do it together. And I believe fundamentally and enormously that transformational relationships, or the we, or the connection that we are all capable of establishing, can take us all further than just a transactional relationship. You're working with people, not just making an athlete a better athlete. You're helping them be more capable and resilient as a person. We're working with the whole person here. Be thoughtful about language, issues related to immigration, marginalization, poverty, et cetera. Extremely important, extremely important. This is an example. I don't have time today to share this story with you, but I learn from my clients all the time. And this story was about a kid that was trying to help people who were being bullied at school, a private school, and kids were being bullied about their size and shape. And he figured out no one else was fixing the problem. The teachers weren't, the parents weren't. And he made kind of an alliance with kids at the school and created a system for how to protect people. It was pretty amazing. Be yourself. It's a privilege to be who you are. It's a privilege to be able to work with our clients and help them grow into who they are uniquely. You're all important. You all have vital roles. I'm so excited that you can make a difference in this arena and that you have interest in health psychology. The world needs you more than ever. Thank you so much.
Thank you so much.
Questions. I don't know if you have time for questions.
Thank you so much for your presentation, Dr. Conviser. You did a great job at answering our questions and provided really good insight into your career. Does anyone have one quick question that we have time for? I didn't see any in the chat so far. Well, if not, we obviously have Dr. Conviser's contact info up on this slide. So if you have any further questions, I'm sure I'm kind of asking for you here. Oh, she's going to send her any questions you may have. Thank you, everyone, for joining us, and we will see you next week for our next presentation. Thank you so much.
Thank you. Thank you.